So hopefully by now, everyone in the room and everyone out in cyberspace that's watching us by video is at least on board with us that this is something we need to do. And we at the center really also saw when the state came to us and said, we'd like you to kind of help us with this, said this is something that we really need to do. So our first charge was to go out there and find what practices exist that we can help disseminate throughout the state so that we can help our providers understand what is the evidence-based practice, what is it that we need to know. And so we have this list here of the existing practices that address tobacco that have the best evidence behind them. The Treating Tobacco Use and Dependence Clinical Practice Guidelines was recently updated in 2008. Most sites hopefully had the clinician's guide when you picked up your packets, but it's available free on the internet. There's a much longer version, and then there's the clinician's guide, which gives you kind of the Reader's Digest version, so it really kind of helps you look at that. The 5 A's is another of the evidence-based tobacco interventions that basically talk about if you take 5 minutes to ask 5 questions, then you're going to help everybody quit tobacco use. And so it's ask, advise, assess, assist, and arrange. I don't expect you to remember those. They exist out there. But it was one of the things that there was a lot of evidence behind, not necessarily in behavioral health, but it actually started in dentistry. So last time you got your teeth cleaned or next time you get your teeth cleaned, you might notice your hygienist asking if you use tobacco and advising you that that's probably not a good thing and going through those kind of pieces. The other piece that we absolutely needed to build on was the integrated dual disorders treatment model. It's something that we know very well and something that we believe very strongly in, that again, to be effective, anything we do has to be integrated with existing care. Anytime we have little boutique programs where people have to go one place for one situation and another place for another situation, really fragments the individual and doesn't really help towards recovery. So we wanted to look at the components and the aspects of integrated dual disorder treatment. Motivational interventions is a huge part of that, as well as some of the other projects that we do. There's a lot of cessation models out there. If you were to just do an internet search of how do I quit smoking, you'll get 6 million hits of everyone has their own little cessation model of what you can do to quit. And there's also the quit line. So there are toll-free numbers across the United States that you can call and get telephone counseling, people to be there supportive and help what's going on. So these are the practices that are out there that have some evidence behind them. And when we started looking at what needs to happen for behavioral health individuals, we really needed to look at how does this fit or how does this not fit. So the models that are out there that are designed for people who have serious mental health issues don't necessarily address tobacco directly. And then the tobacco interventions that exist out there really aren't designed for our population. And so when we've talked about some of this unique interplay, some of the brain chemistry, some of the interaction with the medications, things like that, it really doesn't address that well enough for people to be able to do effective treatment. And then any typical research project that's out there, especially on pharmaceutical methods, the exclusion criteria is if you have a serious mental health issue or if you have an active substance use disorder. So when we look at the efficacy and safety profiles for the different pharmacological interventions, we need to recognize that these have yet to be tested. Excuse me. The last piece is that most of the existing models only focus on people that say, I'm ready to quit right now. And so we'll talk in a minute about the whole range of people who use tobacco. Excuse me. So we set out and developed the tobacco recovery across the continuum model. And so we want to take a few minutes to kind of help you guys understand what that model is, and then focus on some of the very specific pieces of that model that we wanted to address today. So in collaboration with the Ohio Department of Health, Department of Mental Health, and Alcohol and Drug Addiction Services, we really worked to pull together the best evidence and bring it into a model that would really work for our folks. We wanted to make sure that it had a strong commitment to consumer recovery, that it was consumer driven and really helped focus on individual goals and objectives, and make sure that we pull in the best of what we know into a seamless approach. So again, folks don't get fragmented care. People can really address what needs to be addressed in a one-stop way. So you have in your handouts the TRAC model principles, and it goes into much greater detail than I'll be going into today, what the different aspects are. But I wanted to highlight a couple of the pieces that are critical to what we're going to be talking about next, which is what are the pharmacological treatments that need to happen. So the first that's absolutely critical is it needs to be an integrated approach. So we've already heard, and hopefully people are on board with, there is this interplay between these serious mental health issues, the medications that we use to treat these serious mental health issues, and then tobacco use. And so if we don't have an integrated approach where we're pulling in everyone who's working with the individual, then we can run into some really serious issues for folks. The other piece that's really critical is this stage-based approach. And this is something for some of the people in the audience, I think, can probably say this better than I, and then others, this might be some new information. So wanted to really stress that this is a critical component to this model. When we talk about a stage-based approach, people need to recognize that when people are looking towards behavior change, it's not the light switch of you're in denial that you have a problem and then you're ready to deal with it. And that's been pretty traditional. You know, either you accept the fact that you have schizophrenia and you take your treatment and you do what you need to do for your recovery, or you're in denial that you don't have a mental illness. And so there's a lot of this light bulb approach out there to a variety of different problems. Whereas a stage-based approach really looks at people are in different places in their readiness to address insert problem here. So it might be tobacco use, it might be exercising on a daily basis, it might be taking vitamins, it might be whatever. And so it really looks at, you'll have some people that don't see tobacco as a problem at all. You'll have other people that say, okay, yeah, tobacco's gonna, is not a really good thing. I read the side of the package, I see all those commercials, but, I'm not convinced that it's that bad of an issue for me. Then you have people that are in that situation where it's like, something's got to happen. Pretty soon, I'm going to make a change and I'm going to do something about it. They're not doing it yet, but they're right on the edge. They're ready to go. They're ready to do something. And then you have the people that I quit today, and now I want to stay quit. I want to do whatever it is I need to do. So depending on which stage the person is in, we as clinicians need to do very different things to help move them along in their recovery and kind of accepting help for the situations that are going on. So if you have someone that says, my grandfather smoked every day, 3 packs a day, and died with a cigarette on his lips, so I'm going to smoke every day for the rest of my life too, your intervention is not going to be, okay, but you're going to die, you need to set a quit date today, let's throw away all your cigarettes, let's put you on this medication. It's not going to happen. You're going to do very different things with that individual than the person who walks in your office and says, I need to quit, but I need help. And so that's that action stage. The person's ready to move forward. Other components of this is the strong interdisciplinary communication. And this is something that especially happens in community settings where we might have a variety of different people interacting with the same person. And so you might have a case manager, you might have a nurse, you might have a psychiatrist, you might have an employment specialist, you might have a peer specialist, you might have a housing person. There's a lot of different people that might be involved in helping someone with their recovery. And if we don't all talk together and know what each of us is working on, again, things can get pretty fragmented to the point of that it could be hazardous. So an example of that might be if the case manager is working with someone on reducing their tobacco use, and they've cut down from 3 packs a day to half a pack a day. So we already talked about that potentially on 3 packs a day, they may need significantly higher dose of their psychotropic medications to maintain a community stability. But now that they're down to half a pack, their body actually has more access to that medication. So someone might walk into their psychiatrist's office kind of jittery, I haven't slept for 3 days, pacing up and down, you got to help me out, I can't concentrate, I can't, and without really knowing what's going on or thinking to assess about tobacco or things like that, it could be perceived as the person is getting sicker, and let's increase your dose of psychotropic medications so you don't end up in the hospital, and we could be leading the person towards toxicity. I mean, that's an extreme situation, but these are things that we want to make sure we think about, that we all kind of communicate and talk about what's going on, partially so we can help support people in their recovery, but also so that we make sure that we're keeping people healthy and keeping on the right track. And then Dr. Chris is going to focus specifically on our pharmacological interventions in a few minutes. We've been gathering information from sites around the state for a little over a year now. And so we wanted to just share a couple of the results that we've gotten from the sites. And so the slide that's in front of you now is talking about those stages of change. And hopefully this, again, will help you realize kind of that spread of people that are not even thinking about wanting to make a change on through the people that are ready to quit. So if everyone who's in this training today were to set up cessation programs, quit programs designed for those action people, I'm ready to quit today, what do I do? There's a few people that are ready for that. But let's look at the proportion of folks that aren't in that stage of readiness that we'd be missing. And so understanding just that range of where people might be in their readiness to make a change is going to, again, help us design our services and our approaches. This also helps us kind of see what's happening in Ohio. We're talking about 75% tobacco use rate. The information we have shows an 81% tobacco use rate in Ohio. Let's go Ohio, ahead of the curve, above the average. But it also kind of tells you the breakdown of the extent of tobacco use. So Chris was pointing out before that a heavy smoker is 25 cigarettes a day, which is a pack and a quarter a day. Well, when we look at about half folks are at a pack a day, but we also look at those pack and a half, 2 packs, 2.5, and 3 or more packs a day, we really need to make sure that we're thinking about the impact that this is having on folks. And we're also seeing an increase in the use in the smokeless with our folks. Now, we don't know that those 6% also use smoked tobacco. We haven't gone to that level to see if they're different folks or the same folks, but it may be that they're using both products, or it may be different people. This is another important question to really be able to tell how seriously addicted to the nicotine someone is. And that's by how long after they get up are they reaching for that first cigarette. And so we can see very clearly a large proportion of our folks are lighting up before their feet hit the floor. And if you talk to people, they're waking up in the middle of the night to smoke in bed and then go back to sleep. So again, this is the indication of just how highly addicted to the nicotine the person might be, and is going to help you in dosing the different products, in helping them come up with other strategies that they can help move themselves through. But again, this is just some important information for us to realize across the state just how highly addicted our folks are. And then finally, and this is one that I was not necessarily surprised to see, but absolutely interested to see, we ask 2 different questions. We ask, what does tobacco use do to your physical health? So those are the lighter blue bars that are to the right, to the left. And so we can see maybe a predicted pattern. People are kind of getting the fact that tobacco isn't really good for your physical health. And so in the much worse, people are saying, okay, I just misspoke. Talking about physical health. Physical health are the yellow bars. Sorry about that. I started looking at where the bars were going, and I realized I misspoke. The yellow bars are physical health. And so we see people would say, makes my health much worse or a little bit worse, maybe nothing, but not a lot of responses that tobacco actually makes their physical health a little or much better. But look at the opposite pattern. When we ask people, what does tobacco use do to your mental health symptoms? Those are the blue bars. See, that's the thing I was focusing on, so that's why I just didn't even see the yellow bars. if we look at those blue bars, we really see this fallacy of that the tobacco is helping their mental health symptoms. And so this is an important attitude that we need to know and understand, because it may very well be some of the things that Chris has pointed out that we need to address in other directions. Is it helping with focus, concentration, mood? Or is it that perception? And whichever side it is, we need to understand that from the individual and work with them to help them move forward and come up with other ways to address these needs without having to use a deadly substance. And so these are the pieces that we just wanted to make sure people start thinking about. And just kind of a final point here, thinking about motivation and needing to really help people look at changes that they might need to make. We have our doctor being very wonderfully helpful with the patient sitting in the room. The best way to achieve good health is to take care of yourself. Your lifestyle is destroying you. You should change your eating habits and stop smoking and drinking. Start an exercise program, get plenty of rest, learn how to manage stress. And so the patient says, "You're right, doc, thanks." So he absolutely brought her out about behavior change. Got to find a new doctor. Okay, so we always have to make sure that we keep that stage-based approach in mind and that we use our motivational interventions to help people move through their change process.